Welcome to our panel discussion here in the Commonwealth Room. My name is Gareth Wood and I am co-founder and chairman of Kids Operating Room, a global health charity providing more than 40,000 children a year with essential surgery across 23 low and middle income countries. It's my job simply to get us started tonight and to introduce our chair for this evening, Shadow International Development Secretary Preet Gill MP. However, before I do that, please can I take a few minutes just to set the scene for tonight's discussion. Global health has a checkered past, an often toxic mix of good intentions delivered badly or bad intentions delivered well. With a global health aid budget of around $26 billion a year and a worldwide effort for health equity, somehow the majority of the world's population still can't access basic health care when they need it. Tonight we should question, why has this happened? How has this happened? The evidence suggests that we have focused on controlling infectious diseases such as HIV, TB and malaria, but as a result, have health systems been ignored at a local level? Instead of building independent health services to achieve universal health coverage, the funding of global health has chosen to see diseases instead of seeing people. So we trumpet the success of giving a vaccine to a child, only for that same child to die from, say, an appendicitis or live their entire life in disability and pain because of a broken bone that we cannot fix. Looking at my own area of activity, 5 times more children die every year from a surgically treatable condition than HIV, malaria and TB combined. Yet governments and donors continue to change little when it comes to investing in health system strengthening. With almost 2.5 billion children in the world that cannot access safe and affordable surgery, I find myself asking, is it enough to just see the disease, or do we need to refocus our interventions so we can strengthen health systems, invest heavily in local people, provide health equity, and set nations free from health aid? This evening you will hear from experts on all of this and so much more, both on our panel and I hope from the audience. And so it's with great pleasure that I pass over to our chair for the evening, Preet Gill MP, and encourage you all to engage in the discussion tonight. Thank you very much.
Thank you so much, Gareth, and I'm delighted to welcome you to today's discussion, which is on the topic of systems, not symptoms, tackling the root causes of the global health crisis. I want to thank, to begin with, the Foreign Policy Centre and Kids Operating Room for hosting and bringing today's event together and for your kind invitation to chair our very distinguished panel. Our discussion comes today in the middle of a global health crisis. And here in the UK, whilst we may feel like we are coming out of the pandemic, around the world it is far from over. And despite the risk of new variants and the fact that no one is safe until we are all safe, for months and months, governments have stalled and diluted the simple patent waiver needed to actually get everyone vaccinated. There are still just 16% of people in low-income countries that have received a single vaccine dose, and we've all seen the vaccine inequity and just the scandal and the concerns that that poses to many of us. But our global health crisis, of course, is bigger than just the immediate pandemic, as we've heard from Gareth. The UN reported that 90% of countries are still reporting disruptions to essential health services. So we're well off track to actually achieve the UN Sustainable Development Goal 3 on global health by 2030. And because of a growing global debt and economic crisis, more and more low-middle income countries are being forced to slash their very basic public services like healthcare. That is why we need to redouble our efforts to strengthen health systems. And whilst we're rightly proud of our National Health Service, here in the UK, despite the incredible strain, of course, we find itself under when we applauded our NHS workers every Thursday. We did it because we recognised their sacrifice was for a remarkable public good. Well, people everywhere deserve the same right to access quality healthcare. We will talk today about how we strengthen these health systems and about what actually works practically so that we can achieve universal health coverage. The UK government, of course, has a really important part to play within this, and I'm really pleased that whilst the new international development strategy, of course, there was much reported before it came out that actually the government was going to move away from global health, it has made some attempts to actually improving global health and strengthening health systems. But I think there are still huge gaps for many of you that have read it in terms of how the UK is actually going to deliver on some of its health ambitions. And we know that in practice, the damaging aid cuts that we've seen over the last 2 years, which have equalled 4.6 billion, disproportionately impacting women and girls in the middle of a pandemic, have had a huge impact on millions of lives, as well as the UK's UK-wider health system strengthening work. I am especially concerned about the impact of the government's decision to cut funding to multilateral agencies, many of which play an essential role in setting the global standards, sharing best practice and galvanising action on health system strengthening. We are clear that in government, Labour would immediately restore the UK's commitment to spend 0.7% of national income on aid, and I urge the government to accelerate its planned return to 0.7% sooner rather than later. This is a brief where the decisions you take directly impact people's lives, and the way that the aid budget was cut so quickly and so callously has meant lives have been costed as a result. On global health, Labour believes strongly, and to borrow from the title of today's event, in working on systems, not symptoms. Of course, campaigners do a wonderful job of pushing governments and leaders to pledge funds towards individual health issues, whether that's malaria, TB, AIDS or vaccines. But the truth is that beyond the bright lights and photo opportunities of international summits, it's the responsibility of government to tackle symptoms not to tackle symptoms actually in isolation, but to do the long-term patient work of strengthening whole health systems. And that is why we must do more to embed health systems, strengthening into the work, the priorities and the governance of our various global health funds and mechanisms. So I'm excited to be here today. I'm excited that to hear from our expert panel on what others are already doing and on what more we can practically do to re-energise global efforts to strengthen these systems. So allow me to introduce them, and I'll ask each in turn to share some opening remarks for a few minutes, and then we'll go to a Q&A, and I would really like the audience to participate within that, so this is a two-way process. To my right, I have Dr. Nema Kazeje. She's the founding director of the Surgical Systems Research Group in Kisumu, Kenya, and is a visiting surgeon for Kids Operating Room and for Doctors Without Borders. She's worked to improve paediatric surgical care in Kenya, Haiti, Central African Republic, Congo, and Liberia. You're most welcome. And to the right of Nema, we have Ben Sims. He is the Chief Executive Officer of the Tropical Health and Education Trust, which builds health partnerships to train health workers across 30 countries in Africa and Asia. He's worked on global health and disability for over 30 years to improve health and social care in low and middle income countries. And to my left, last but certainly not least, we've got Professor Dina Balabanova, who is a professor of health systems and policy at the London School of Hygiene and Tropical Medicine and has over 20 years experience in researching health systems and policy in low and middle income countries. And Dina currently serves on the technical team of the Lancet Global Health Commissioning on financing for primary health care for low and middle income countries. So let's start with you first, Nema.
Thank you so much for that kind introduction. It is a pleasure to be here with you today. I just arrived yesterday evening from Turkana. Turkana is located in the northwestern part of Kenya and hosts about 200,000 refugees. It's an arid place. There's an ongoing food crisis. COVID-19 is still with us, and we're seeing a new wave of infections. And so I'm really, really happy that today we're talking about systems and we're talking about the action that we need to take to make a difference. And it's a real pleasure to be here with you today. And it's an honor to be on the same platform as Professor and also as you, Mr. Sims. And thank you, Honorable Gill, for your leadership and for chairing this session. And so just to begin with my comments, what I would like to first say is that the systems we have in place now, including our health systems, do not serve the most vulnerable. I'll say that again. The systems that we have right now do not serve the most vulnerable. Women and children are being left behind. And so when we consider Turkana, for instance, it has a population of about 1 million. 60% of that population is made up of children. But when you look at the health system, it is fragile. No specialists, no oxygen, basic infrastructure is not in place. Sometimes there's no water, no electricity. And so how can you provide care for women and children in those conditions? Turkana has some of the highest maternal mortality rates in Africa, the highest under 5 mortality rates. And that has been the case for ever since Kenya gained independence more than 50 years ago. So that's the problem. And we know what needs to be done. And so we need to move away from rhetoric, as someone said earlier, and we need to move into action. As a pediatric surgeon, a couple years ago, I saw also that in addition to the lack of infrastructure, the lack of a workforce, the lack of equipment, children in the refugee setting had no access to pediatric surgical care, often life-saving pediatric surgical care. If you had the misfortune of being born with a birth defect, that was a death sentence. If you were lucky enough and you could gather some money, you would have to drive 13 hours. That's the nearest facility with a workforce, with the infrastructure, with the equipment. And so imagine those conditions where 60% of that population is made up of children. And yes, there is work going on, different organizations, including UN organizations, and yes, they're working very, very hard, but surgical care has not been included in that essential health package. And so what we're saying right now, yes, we will vaccinate those children. Yes, we will feed them. But if you happen to fall from a tree, or if you spill some boiled water onto your chest, that's it, we can't help you. In June of 2021, KidOR and other partners decided, well, this cannot continue. Because the usual narrative is that surgical care is too complicated, it's too expensive, it can't be done. Don't even think about it. I've had that so many times. But we decided we're doing it anyway. And KidOR installed the first operating room for children in a refugee camp in the world. We got the infrastructure in place. We got the equipment in place. We got community health workers involved so that they knew what needed to be referred, when, and how to follow up on patients after surgical care. And within 6 months, we saw a difference. We saw an increase in the number of children accessing life-saving surgical care, a 40% increase. And we're on track to double that number by the end of this year. We have mothers now walking 100 kilometers, bringing their daughters with birth defects. Imagine that. We have unaccompanied children walking all the way from South Sudan to Kakuma. One came with an acute abdomen. He had walked for 7 days to reach us. And so it can be done. Those children with birth defects had their surgeries and they're now going to school for the first time. And yes, we've done it, but it's not enough. We need more investments. more investments in infrastructure, more investment in equipment, and most importantly, more investments in building the capacity of the health workforce, including the doctors, the nurses, the community health workers. And that's the only way we will reach some of these global targets. SDG 3, universal health coverage. The only way we can reach those targets is by achieving equity. And so I'd like to offer 3 solutions. One is that we need to change our systems so that they serve the most vulnerable. We need to invest and strengthen our systems, invest in the equipment that is needed, in the infrastructure that is needed, and most importantly, invest in people. That workforce is the most important ingredient. And number 3, we need to measure our systems and hold them accountable. That is so important so that we can be responsive to the changes that happen, so that we can adjust some of our interventions. And so I'd like to end there, and I look forward to your questions and your comments. Thank you.
Thank you so much, Nema, for putting that into context in terms of some of the issues. Of course, when we think about the pandemic, that's all that comes to our mind, but of course it's the very basic healthcare systems that people just don't have access to. And if you live in a rural village and you have to walk for hours because you don't have transport, it's even much more difficult. And I know that there'll be lots of opportunities for questions. I'm going to go over to you now, Ben, for your opening remarks. Thank you.
Thank you so much. And thank you very much for having me. And congratulations. I'm so impressed with KidOR. I love this report, by the way. So I think there are copies here. And thank you for those wonderful words. Gareth Woods, in this document, you call for a genuine transformation in global health, and I think that's what we're here to talk about. I'm going to talk from the perspective of FET, which is best known for its partnership with the NHS, with the various institutions of the NHS. So our focus is very much on health workforce and that aspect of what WHO calls the building blocks of a health system. Gareth also talks about quality healthcare. So although he quoted the lack of access to healthcare, actually we know now from the Lancet and elsewhere that it is the poor quality of healthcare that is now killing more people than the problem of accessing healthcare. And an estimated between 6 to 8 million people are dying every year because of poor quality healthcare. And so the challenge that we really face is to drive up that quality healthcare, and I think that's what you were talking about, Nema, earlier. It's an exciting time to get involved with the health system strengthening debate. I want to highlight 2 things that have happened relatively recently. One is the WHO launch of the Quality Toolkit last week. So those of you who are slightly nerdish and want to get into health system strengthening, go and look for the toolkit, which provides a roadmap for taking action to the health system and a series of practical suggestions. You might be disappointed to note in this room that although the word quality appears 310 times, the word surgery does not feature. Closer to home, we have had the wonderful, I'd say wonderful, FCDO document on health system strengthening. And that was published in December. And it's worth a read apart from anything else, because this is what our government says it will now do. The opening sentence sets the tone, and it calls for strong, resilient and inclusive health systems as a critical foundation upon which solutions to the world's most challenging health issues depend, including, as you've just said, reaching the SDG goal. It also acknowledges the symbiotic relationship between economic development and the development of health, using a stat that over a quarter of economic growth can be traced to, in low middle income countries, can be traced to investments in health. and it emphasises the quality as well. And underpinning this FCDO paper is very positively, I think, pride in what we have achieved here in the UK. You've mentioned it already, Preet, but the fact that the NHS is one of the oldest and largest universal health systems delivering universal health coverage is something we can be proud of. And by the way, in the sense of being proud of the mistakes as well as the successes, it's just this wonderful system and talent of people who have learnt a lot about the business of delivering healthcare. And in that sense, I think shared openly and honestly is a great resource for the world. But the charity I work in, I suppose the perspective I want to bring is particularly looking at the intersections. We often think of health system strengthening as a project over there, and not here. And the things that slightly obsess me are the interconnections. So I'm going to stress three interconnections. One is the obvious one, which is the skills sharing, which I've kind of referred to already. We do this through the model of health partnerships, and in the last decade, for example, NHS staff have trained over 100,000 health workers in low middle income countries. And we see in this process gains for us. There is reverse learning, the wonderful thinking, I don't know whether you've read it, of Nigel Crisp, Lord Crisp, Turning the World Upside Down Again, has been republished this year. And it's full of inspiration about how you can be humble whilst also giving, so you can learn while also teaching. But the second interaction has to be this theme of workforce. 1 in 3 UK doctors were born overseas. 1 in 8 UK nurses were born overseas. It is an astonishment, isn't it? The extent to which we are now reliant on overseas health workers. We always have been, by the way. Since the beginning of the health service, we have asked for help from members of the Commonwealth. We have asked Indian doctors to go to the centres of town and to the remote parts of the countryside where we can't recruit people to work. So it's not new, but the scale of recruitment is unbelievable. And in the context of at least a 12 million person shortage across the health workforce globally. So we have the spectacle of your president in Kenya inviting us to employ unemployed nurses. And I'd love to hear your thoughts about that. In inverted commas, unemployed nurses. And we applaud the references in the FCDO paper to the code of practice on the international recruitment of health workers. But this doesn't actually address our ethical responsibilities. I am a fan, wait for it, of Andrew Mitchell, who introduced 2 years ago a private member's bill on this very topic. And I can't do his voice, but I kind of want to read out some of what he said, not having my glasses on. When we persuade a doctor from the developing world to come here, we do so in the knowledge that our gain will inevitably be that country's loss. What I am describing, the export to us of their doctors and clinicians, is reverse aid, not from Britain to help developing countries, but from those developing countries to help Britain. And it's clearly wrong, Andrew Mitchell says. It's not his voice, but it's his words. And he goes on, so let us accept our moral obligation to people much less fortunate than ourselves, but also meet the needs of our citizens, ensure that they have the best possible healthcare. For every doctor or nurse we poach from a developing country, we should ensure that that developing country, on losing their trained professional to our advantage, receives the existing British development budget sufficient resources to train and replace them. And he comes up with this phrase, 2 for 1. I think it should be about 5 to 1, but Andrew Mitchell plummets for 2 to 1 at least. Because think of the savings we make by poaching people who've been trained elsewhere. That's why, of course, we have the health workforce crisis in this country. because we haven't invested enough in training. There's a third there's a thing I'd like to say in the context of this, which is also to acknowledge what we're now calling the experts in our midst. We all often talk about global health as being that activity which an elite few people can participate. They need, maybe they need a posh accent like me, I don't know, but they need an airplane ticket, they need a nice job title. They can join the club. But actually, the 1 in 7 health workers that work for us, who were born overseas, are experts in our midst. They too have a knowledge of those health systems overseas. They are connected through diaspora and through lived experience with those health systems, and many of them, by the way, are volunteering their time and helping. We need to recognise their expertise, thank them for the job they're doing here, but also celebrate their expertise in relation to global health. And that means squaring up to racism, it means squaring up to unconscious bias. And some of the amazing insights we've got into inequality, into how racism plays out over the last 2 years. It's a very exciting time when, as Nigel Chris says, the world is being turned upside down. So you could think that the emphasis on health system strengthening is an obvious one because we've just had a pandemic, because we've got this crisis in workforce. But as Bill Gates has written in his book that published this year, the world did not prioritise global health until it was too late. And the results have been catastrophic. I've got a wonderful stat, by the way, which I want to tell you. You know that video that Gates recorded about how to avoid a pandemic? He did it in 2015. It's been viewed 43 million times. It's impressive, isn't it? Until you know that 95% of those views happened after the pandemic. So no one was listening to him in 2015 when he was warning about the pandemic about to happen. But we're all listening to him now. And there is that real fear that Gates' warning will be ignored. You've been very positive about the international development strategy and optimistic perhaps about the focus on health that we might see in that. But I feel very pessimistic about the short TikTok attention span of the UK and other countries that are in the position of power here. And so I worry that the devastating impact of the reduction in aid will stay. I worry greatly about that. FET, by the way, lost £48 million of funding that we were going to grant to brilliant people across the NHS, which would include in the field of global surgery. It was just a fantastic expression of global Britain, and not of what Richard Horton has described in the Lancet this week as dismal Britain. It's a heartbreaking opinion piece that Richard Horton has published this week. And if you think what I'm saying is nonsense, read him, because he knows what he's talking about. He ends with this note of optimism, which is science is self-correcting, and a national self-correction will dawn. Until then, we must struggle, he says. I think KidOR are struggling in a brilliant way. I think probably most people in this room are committed to that struggle, which is why you're interested in this topic. But struggle we must, because there's no time to lose. And I think at the core of the struggle must be to persuade the government to return to 0.7 commitment, to recognise the intersectionality between our health system and health systems overseas, to recognise the inevitability of future pandemics. We do quite a bit of work on antimicrobial stewardship. It's not a pandemic, but it will be equally devastating. We need to wake up to how central global health is to the future of this world. So thank you very much for inviting me to speak.
Thank you so much, Ben, and thank you for all that you do. And actually, lots of interesting points. I have to say I agree with Andrew Mitchell. I think you're absolutely right. I've got one of the largest hospital trusts in the country, and actually I was talking to my chief executive about exactly that. I mean, they have a program where they have lots of doctors from the Middle East and Pakistan here for 5 years, which they train and they go back. And so actually their countries do benefit, but you're right, we've got a global shortage, especially of nurses. And we are, we still have a situation where many trusts are still recruiting from the Philippines and places like that. So, and on the aid cuts, I mean, I think you're absolutely right. I mean, absolute scandal, the story that we put out just 2 weeks ago, doing lots of research. It's the G7, the Prime Minister last year, made a commitment to saying that surplus vaccines, he will donate 100 million to the Global South. We had to destroy 600,000 in August alone because it expired. I mean, just imagine. But he also said he wasn't going to offset the cost on the ODA budget. What has he actually done? We procured them at about £2.30 and he's decided to charge the ODA budget at £4.50. So not only have we had cuts to the aid budget, we have got this kind of trickery going on, which we're having to try and expose. So yeah, absolutely, I want to be positive about the 2021 strategy on health system strengthening, and you're right, I think there is a big challenge in the international development strategy as to how the government's going to deliver its priorities, because we don't know that. We don't have the level of detail. So thank you for those contributions. I'm now going to go to Dina.
Thank you very much. I'm incredibly inspired listening to all these experiences from the field and something we learn from, and your experience of connecting the NHS with the issues in low-income countries. So when I first got this invitation, I was really surprised and very inspired, because I think there is not enough conversation around health system strengthening. We all accept this has to happen, but as you said, actually we don't know how. We don't know how to do it. There are a lot of. I've been in the past few weeks to various meetings of donor agencies. They're still into vertical programs. So people are saying, yes, we have to do health system strengthening. We need to do together, but how? Everybody has different constituencies. It's really difficult in practice to achieve. And I wanted to say a few words. Why, and what can we do about it? So first of all, why? I mean, we don't even know what's a health system. According to the WHO definition, it's any activity that leads to health improvement. And we know that in low-income countries, 80% of the healthcare is outside the facilities. In India, for example, outside public facilities. A mother taking care of a child, or that she's part of the health system. What should we do about it? And we have cases such as we work in the Philippines, where people don't seek care for many cardiovascular disease or hypertension. They go to their social circle. They wouldn't even go to their community health worker. So the question is, what do we do about it? What's the boundary of the health system? And do we need to understand a little bit more about the complexity and how the health systems are not just building blocks, series of boxes, but actually more complicated? If I can give an example of these moving pieces with surgery, you could have surgery services, say, for example, in hospitals, district hospitals, and we see this in places such as Nigeria, where you don't have effective primary health care. So people can't get diagnosed, they don't have the right referral, they very often are shifted around different type of facilities, they don't have the proper pathway, they may have surgery and then not have a proper follow-up. So they have complications, they have to go back, they are diverted to the private sector. So you can't just invest in equipment and operating theaters. You have to think about these processes. How do you connect different professionals and levels of the system? So we've been calling for this to happen, to really have a more comprehensive view of what you need to do. So when I talk about surgery, when I was invited here, I would like to talk not about service provision, about outcomes. So the idea is that you want to have good outcomes. If people need surgery, that's the idea. So it's not just about operating theaters. It's about skills. It's about sometimes connection, even community level, the knowledge where to go. We find that incredibly high number of people don't know where to go. For example, they don't know where they will be treated humanely and so forth. So another example I would like to give, and I spoke earlier, the unintended consequences in a health system. So we know that places where there's been investment in health system, for example, theaters and better facilities, we immediately see high out-of-pocket payments. A lot of them are informal payments, and this is the highest level is for surgery. So we need to be aware that this is what happens. We published recently a paper on Tanzania, and this is what happens. People pay to get access to the top surgeon. People pay for delivery. It's absolutely people pay in Nigeria. That's it. Although it's part of the national package, you're not supposed to pay. But this is the reality, and they are expected. Some of the payments they brought were about £45, and these are women from villages who don't have the money. They are asked to bring 5 bottles of Dettol, gloves, boxes of gloves, because this is needed. So I'm just giving an example that when you think about improving outcomes, improving services, you have to think about what happens, and surgeons who divert people to private sector. So these are all part of the reality, and we have documented in various settings. Another issue is, again, when we think about improving health systems, we think about service delivery and financing, and this is important. But we don't talk about the upstream parts of the system, such as regulation, having the appropriate rules. So we know that, for example, in Nigeria, I was there recently, and there is a lot of informal task shifting. So we know that in places where task shifting has happened in a very regulated manner, such as Malawi, there have been trials, clinic officer delivering C-sections with very good outcomes, actually. But these are supervised cadre. We are finding that there is a lot of ad hoc cadres without any proper supervision operating. For example, we found in Malawi, suturing is done by porters. There are people who just observed how it's done, and there is somebody coming there, all the doctors, nurses are absent. So what can they do? They do it. And this is the reality, and this is the community coping strategy. So the question is, how can you engage with that? Is there any way to support people who may be lower in the hierarchy to improve their career progression? So be more innovative about what can be done, given this, in some places, 70% absenteeism of health workers. So I think we need to think about the real life. This is the situation we're facing. Then the second point I wanted to make is a part of my work on the Commission on Financing Primary Health Care and other projects. We really looked at the political economy of the strengthening health systems, and that's something that I'm sure you have a lot to say. And I started questioning what we have been doing so far, because we approach this issue as a technical issue, and it is really not. It is really a political issue. When we looked at countries that have improved outcomes, Brazil, Costa Rica, various other places, it's about the social contract. It's not about the technical solution, and Thailand. So that's something that we have not engaged very well. We kind of shy away from that, and most donors, most governments, they just, I think there is limited understanding of what can you do about it. But there are some emerging work around strategies, for example, building coalitions involving not just NGOs, but involving technocratic elites, and that was an example from Thailand, where just finding the right coalition could help to move things forward. So there are certain strategies that could be done. And then again, health systems is a social system, so there is a lot of informality in health systems. So even places where there is investment, there are resources coming, we find that a lot of decisions around protocols of care, about how care is provided, are done on an informal basis, agreement between different stakeholders. And I think we don't engage with that sufficiently, because it's often not visible. People do favors, and this is very often linked to local political groups or strategies. Certain patients get access while others can't, and that's part of the inequality. What you talked about is part of the societal inequality. It's not just the health systems, it's bigger than that. That's why we have this issue. And again, the third thing I wanted to mention is we all talked about the really decrease in resources and investment. So that's really there, and I think it's difficult to talk about efficiency given the really low level of resources, as you know. However, I would like to argue that we forget one aspect, which is about the software. So it's not just about investment in equipment and supply chains, but it is about people. It's about training. It's about how do you retain good people working in even peri-urban areas, career progression, opportunity support. I think these are the things that we don't talk so much. We almost presume it's there, but it's not, and that's why people leave. We see a lot of attrition. People get trained, including surgical skills, and then they leave, and there are a lot of studies why, and it's obvious. There is no support, there is no progression or interest in what they do. So how do we move forward? What are the several things I was thinking I can mention today? First, investment has to be across different levels of the health system. You can't just invest in one particular service and hope it would improve. You have to look at the whole pathway and follow the patient. So we've heard this buzzword. I hope it's not buzzword, but it's patient-centered health systems. And there's been a landmark WHO report and also World Bank issued report. And it's all about this: follow the patient, find out where they want to go, where can they go. You can't expect people to work 5 days, whatever hours. This is not sustainable. And also understand their needs, understand who they trust, the level of trust, and all this, and configure the services around them. And that's a way to improve responses and resilience. The second, something that we've been working on, and quite surprising results, looking at the Ebola responses, the Ebola epidemic responses now, the fact that there are a lot of local resources, a lot of local energy there, that's very often ignored. So donors come, they invest in programs, but there are already local structures and local ability and people, good people who are there, who they need something different. So I think understanding this local existing capacity and engaging. Finally, I think the biggest issue for me, and that's something that I would have said the same comment 15 years ago, and unfortunately we're still here, the vertical programs. We can't get away from that. It's really, that's one of the most damaging things in global health, and it sounds really archaic almost saying it here. We talk to our students and they're saying why this is not changing, and we have books and books written, but the fact is that it's not. And people come and say, oh, we have this great program and we have this is a facility. And we go to Nigeria and we go to primary healthcare post, and they said, okay, this area there, it was built with TB money. This is only for TB, nothing else. So why? I mean, why can't the donors work together at any level? I don't still have a very good explanation, to be honest. And finally, I think to strengthen particularly surgery outcomes. So in summary, I think one should look at the whole investment portfolio. What kind of things need to be covered? It's not just about service delivery, how many children are treated, but what is there to optimize diagnostic, what is there to optimize post-operative support, and look at also the broader social determinants of health. If the children receive care, we know that they come home, they're expected to work on the field, they're expected to help their family. So how can we deal with that? And we often have recurrence of health issues. So yeah, a broader holistic perspective of the needs of the population. Thank you.
Thank you so much. That was absolutely fantastic, Dina. I know there's going to be lots of questions, so do have a think about some of the questions, but I'm going to kick off and I'm going to start with you, Dina, because I think you've talked a lot about some of the practical steps that we can take, and I think, taking away, listening to you, some of the things that donors could do is be flexible in that funding and what it's being used for, because I think that rigidity doesn't actually help. But I know that there's a lot of campaigners and probably lots of global health groups here in the audience, and they'll want to do their part in sort of, a push to sort of overarching push to strengthen health systems, which I think can often feel quite daunting. What's your advice to them in what they could be doing? I know you talked about how they work together and some of that, but can you expand a little bit more? What could they do in the audience? What's your message to them?
I think even taking a broader perspective of, for example, investment in surgery, investment in TB services, they have to, in a way, think what are the sort of broader determinants of improving health outcomes. And very often people look in terms of what is the return on investment, or how many people you can treat, what is the outcome, and that's very often like a measuring impact. But I think impact should be measured maybe over a longer period of time, understanding of what kind of mechanisms are possible. And we have seen good examples. For example, years ago we had swaps, if you remember swaps, in a lot of sub-Saharan Africa, sector-wide approaches. So also basket funds, donors putting money together. So that's not, again, it is, I think people know what to do. It's more, and I think some governments are actually very good at pushing for this to happen. Ethiopia has refused funding. They've really been very strict about what you can fund. And so it's also the strength of the local governments. I think the district governments, I'll be interested in Kenya. Their districts have a very strong capacity. So we are increasingly seeing that at subnational level. Because some of these countries are big countries. You could have a lot of, some parts, for example, of Nigeria, they have much better performance because the states have autonomy and they can take charge of how they aggregate the funding. So, but I do think the donors know what to do. That's my impression. I think it's more political. They want to do it.
Right. That's great. And coming to you, Nema, you've talked about surgical capacity, which is really an important part of sort of the resilient health system. Why do you think, from your experience, why is it so important, and what has been some of the main sort of challenges and barriers that you've actually faced?
In terms of building
the
surgical capacity?
Yes.
I would say if I was to choose one area that is a challenge is the workforce.
Right.
And I think that's the most important piece of any health system. Because you can have the infrastructure in place, you can have the equipment in place, but if there's no workforce, it's not going to work. And a trained workforce that has leadership and governance will make up for some of the limitations in infrastructure or equipment, but that cannot happen the other way around. And so that's the most important ingredient, in my opinion, anywhere in the world. It's the biggest challenge. So there are many countries in Africa that do not have not even one pediatric surgeon, yet the population is half the population is pediatric. And we are way behind in terms of developing and training our workforce. And I think the surgical system is critical because it has a way of upping the health system. So if you are in a district hospital, the minute you add a theater and you can do C-sections to save a mother's life, it changes the level of that hospital. It changes how communities view that hospital. And so the surgical system is not just about surgery. It's about lifting the whole system up, because to have a theater, it means you have water in place. It means you have electricity in place. It means you have infection and prevention control. There's water and soap to scrub before a case. It means you have instruments and you have people who are keeping those instruments clean. So the minute you add surgery, it improves the whole hospital. It improves pediatric care. It improves maternal care. It improves adult care. And it raises the level of that hospital. And I wish it was recognized more. And I absolutely agree with other comments about the destructive nature of vertical programs. And we do not want to do the same thing with surgery. We want to make sure that surgery is integrated with the whole system and with other health conditions. And it is. If you're treating an HIV patient, they may have a cancer that requires surgical care. If you're treating a pregnant mother, they may need a C-section. If you're treating a pediatric patient, they may have a childhood cancer that requires surgery. And so it is a critical piece that is often not recognized. And it fits, it is a cross-cutting intervention. And the biggest challenge we have now is the workforce, and I hope we can have more discussions on how we can improve that and do it in an accelerated way. because I'm seeing a shift towards longer training, which may not work for Africa because we just can't afford having clinicians training for 10 years. It's just not pragmatic, and so I hope we can have more conversations about that.
Definitely. I mean, I think there's lots of really key things that you've mentioned there. I'm going to pick up on that point because, you know, health workers, as you said, are central to a really good health system. But of course, pay, work conditions, all of that really, really matters. And the brain drain, as we talked about, as Andrew Mitchell's comment. So, Ben, what can we do to improve this situation, especially for the lower middle income countries?
Yes, and Dina talks about, isn't it wonderful to hear the term software and to hear it used in reference to human beings. I'm led to believe that if we had managed to retain the nursing staff within the NHS, we wouldn't actually need to go out and recruit. So the heart of our problem is retaining people in the system. And we know through COVID the pressure people have been under and the importance of well-being, and it's way beyond the clap that needs to happen to support these systems to keep people. So retention and well-being seems to me absolutely crucial, alongside, by all means, investing in training greater numbers of people in the first place. And there is some exciting work. The government has a future international workforce programme. It's very modest. Forgive me for being so, for emphasising that. But what's really interesting is that they are trying to work with refugee communities, for example. So not just to identify people in refugee communities who have medical or health training, but to provide pathways to employment for people in those communities, to train them as health workers, so that they can then go on, better their lives, find employment, wherever that might be. So I think the whole sort of issue of how we treat and look after our health workers and how we increase the numbers, I think there are some innovative ways we can do that. May I just say, by the way, of course the NHS, going back to that political point, was created in 1948, 3 years after the Second World War. Austerity. Unbelievable. So if you want an example of a political choice, a moral choice, then the NHS itself is that example. 1948, when the country was on its knees, this country chose to create the NHS. And there's a very exciting initiative, isn't there, from Rob Yates at Chatham House, which is looking at those issues around the political economy of health. Because I think it's true, it's about politics and resources first, humans second, and perhaps technique third. And then finally, I just want to come out. I'm sort of being brave and outing myself as a diagonalist. Am I allowed to be a diagonalist?
Yes.
So there's this dichotomy between horizontal health system strengthening and vertical interventions. How exciting that we're on the cusp of eradicating polio. How exciting that 35 million people living with HIV are alive today, thanks in part to the work of the Global Fund. From 2000 onwards. It's hard to resist that sense of excitement. We want that in surgery. We want to recognise that 93% of the world's traffic fatalities happen in low middle income countries, and a big proportion of that will be because of lack of access to surgery. But I find myself tempted to be, as I say, a diagonalist on these topics. I'm just sort of looking nervously to my left, seeing whether I'm allowed to be a diagonalist or not.
Brilliant. Thank you so much, Ben. Thank you to our brilliant panellists. I'm going to open it up to the floor. If you've got any thoughts, any comments, any questions. And please do say which organisation and your name when you do ask. Everyone's, yes, great. David.
I might go first if I may. My name is David Cunningham. I'm the Chief Executive of Kids Operating Room. When all is said and done, more is usually said than done. And I wondered what single action the panellists would take to try and convince donors to move from rhetoric into action.
Brilliant. Let's kick off with you first, Emma.
Oh, okay. So as I mentioned earlier, we have the policy frameworks. Health is a human right. All of those things are in place, and we know exactly what needs to be done. And I think it's almost a self-feeding mechanism. And it may start with what we're trying to do in Kakuma, trying to get different UN agencies together to show that it can be done and it can be included in that essential health package. And often you don't convince people from an office in Geneva or from the Ivory Tower. You convince people by being on the ground, getting your hands dirty and getting the work done. I think that's convincing, and that's what I've done, and that's what I'm committed to.
Fantastic. Thank you. Come to you, Dina.
So, I was thinking about that. One thing I've observed that people like to hear about success. 10 years ago we did a report, Good Health at Low Cost. It was continuing to look at something that was done previously, but we did new research to look at countries that with resources that are lower than others, the same level of economic development, but they have achieved much better outcomes. For example, comparing Bangladesh and India. Bangladesh is they call it Bangladesh miracle. They've achieved incredible improvement in maternal child health with much less resources per capita. So a few cases like this, just to look at what they've done. And I think, as you say, almost highlighting cases where this sort of donor, multi-donor, very often it's actually the national government. The national government is where resources can be integrated. That's why I think very often I'm more optimistic about the roles of the national governments, especially with the right coalition, where they have political momentum, political will to change things. I think the national governments could be very, very active and demanding from donors. We saw this in Indonesia with the expansion of universal healthcare program. Even in many other countries, this is now happening, Nigeria, China. So I think the big argument is economic development, because ill health ultimately poses lots of burdens on the country. So there is increasing argument looking at macroeconomic impact of poor health. So I think merging these arguments, maybe it's not very humane, but actually that is something that is being heard more and more, that given the level of non-communicable disease, which is very much incapacitating in lots of countries, and the impact on the economy. So that's a very sort of big argument. I'll stop here.
Great. And same question to you.
Gosh, it's terrible question, David. Sorry, because it's very hard to answer, isn't it?
Yes.
I was just thinking about, the statement of WHO in 2015, the Lancet Commission. I reread it recently, and it's just full to the brim of facts, isn't it, around why something needs changing. And so it's not the arguments that will change it, is it? There's something else that's going on. And maybe it is that slow slog of building coalitions of politicians who understand that there's a moral argument here about our responsibility in the UK to the rest of the world. And maybe that's the single thing. But the one I'm going to choose is a compulsory tax on all countries to support the World Health Organization, non-negotiable, and unrestricted funding, by the way, not restricted. Do you know, WHO, I don't know whether it's improved, but they have a single person responsible for surgery. It's absurd, isn't it?
I think he left.
He left.
Yeah.
And he used to, do you know, he was an eminent US surgeon. He used to pay for his own flights
Yes.
because he wanted to make a difference, but because he wasn't given a budget also. Anyway, WHO has, I think, under Tedros' leadership, the first African to lead the WHO in its history, has demonstrated the kind of leadership the world needs. They haven't been shy about pointing to the inequities that you were talking about, Preet, in terms of vaccine inequality, etc. And I said, so my magic wand would be, compulsory tax on all governments, so that WHO is fully funded and empowered to speak up as a global voice.
Brilliant. Thank you so much. Any questions? Wow, that's fantastic. We'll go the lady there, yourself, and then the lady behind.
Hi, my name is Dipa. I'm from Indonesia. I'm currently studying here at biology. So my question is, what is your view on pandemic preparedness fund that is recently established by the G20? To what extent do you think it can support health system strengthening efforts instead of again diverting attention and human resources like the vertical health program?
Did you catch that, George? Or should we repeat it?
This is the preparedness mechanism
Pandemic preparedness
that
fund
Bill Gates has been advocating, for example, in his book. And the excitement about that is Bill Gates is transparent. He's excited by the technical stuff and the kind of team of people beavering away at analysis. I think where he's been taken by surprise is vaccine hesitation, for example, is a major issue. Human behaviour is a major issue, and so you can't just create a preparedness mechanism which pulls a lever and everything's fine. You need to engage, as we're saying, in that broader health system strengthening in order to have a system that can cope with the oddities of human behaviour, as well as delivering the science and the tech of modern medicine. So that would be my worry about it. The good news is if they take Gates' advice, then it will be within the WHO, which is a strengthening of the global health system rather than a further sort of dividing up quite. And it seems to me the fact that he's proposing that is a vote of confidence that the WHO is now better equipped to respond to emergencies than it used to be. Hence, people didn't look to WHO when they created Gavi, when they created the Global Fund, etc.
You've got to have resilience within people to be able to deal with pandemics, because if they get unwell, people will, suffer invariably differently in terms of, what access to healthcare, what vaccinations you've had, what immunisations you've had, for example. So it will always hit certain parts of the world differently to other parts. So it's only a aspect, I think, pandemic preparedness of the whole sort of system that we've got to really strengthen. But I'll come to you.
Well, I'd like to, I agree with you, but in addition, I'd like to bring up the dimension that there is we already have resources within global health, but those resources are not always maximized. So if we look at how, even the UN functions, it's a lot of land cruisers, a lot of salaries, and that baby that needs an operation is the last one to benefit. And so I think there needs to be some self-reflection in terms of how current limited resources are being used and whether we could shift things and do things differently so that the most vulnerable people actually benefit from those limited resources. And so that's one additional comment that I would make in terms of preparedness, resilience, and our response as the global health community.
Great, thank you. Indeed.
So I think these funds and these vertical programs and this particular program could be used as a force for good, but at the same time as this is happening, there are initiatives within WHO, within World Bank and Gates Foundation and others around strengthening primary healthcare. So in the past 2 years that has been a big theme. So I would say even if it's not strengthening the whole system, starting somewhere, I think we saw here what happened in the UK. Pandemic preparedness should be integrated within primary healthcare because this is ultimately there needs to be a place, and I believe from what we have learned there needs to be a place in every community where people can go with whatever problem. There needs to be a central point, and there's increasing interest towards the UK model of family practice, and of course that's not immediately transferable, but the whole idea is that you have a point where everybody knows where this is my point. I can go there for anything. I'm worried about vaccines, I'm worried about immunization, whatever. I think this is creating another fund that's not, it could be a good thing, but it has to be linked and integrated. Otherwise, we see the same fragmentation, continued fragmentation and duplication. So we see, I've been in places where they'll tell us, okay, there are 2 Land Rovers. One day we're going to this village because we're doing maternal care. And then tomorrow we're going with the other car to the same village because we're doing something else, awareness raising. And then we are just, why? This is already a waste of money. We see it everywhere. So it's efficiency argument. It's also improving sort of the package available to people, close to them, close to communities.
Great. We'll take the next 2 questions together. So just yes, yours, and then the lady behind you.
Sure. So I'm Justin Bickles. I'm a donor with my wife to KidOR. So what I do for a living is I come up with business ideas, I create businesses, match them with institutional capital, and it all seems to work. Why is surgery overlooked? It's such a fundamental point. Why is it overlooked?
Great question. The lady behind you.
I'm Audrey Glover from FPC. The lack of a workforce has been stressed, and it's certainly true in this country, I understand, at the moment, a lack of doctors and nurses. What can be done to try and reverse that so that there are more doctors and nurses prepared in this day and age to proceed in those professions?
Great. Shall I kick off with you first, Ben?
Gosh, I'm going to go for the second answer. I think investing in training, removing bursaries, reintroducing bursaries, etc. So there's a lot of things around cost. I think where I get excited as a kind of disruptive, enjoying disruptive thinking is, are we spending too much time training our health workers in this country? Is some of the task shifting that we see in low middle income countries actually relevant to us? Is it the rather large and splendid walls of the Royal Colleges that is deterring us from breaking down those silos where specialists ply their trade? So in Nigel's book there is that invitation to turn the world upside down and think about how the UK might learn from those kind of initiatives. And I think that is, difficult territory, isn't it? Because you are challenging people's professional boundaries. But if you think more in terms of humans that enter health service and go with their skills and their abilities and see them take on more responsibility, then I think there is a pathway to seeing how you can break down the ways in which we're complicating the training of health workers. So more cash, but a different approach, perhaps. And I don't know what the answer is to the global surgery. I really don't. I genuinely don't. It's such a good question. I just don't know. It doesn't make sense, given the stats, given the strength of the arguments.
And it's always been like that.
Yeah. I mean, it's probably, normally there's a queue, and it's the urgent that gets treated first. Hence, in this wonderful document, talking about communicable diseases and people dying, and so communicable diseases like HIV are first in the queue because you're saving lives. When you get to disability, which is where I've spent much of my career, for example, disabled people aren't regarded as economically useful. So what's the point of investing money in correcting a disability or minimising an impairment? But I don't know. I feel on the edge of my competence answering that.
I also think, unfortunately, if you look at the last 10 years in terms of how we spend that money, we've had about 5 or 6 changes of Secretary of State. Global health and sort of making the case for universal health coverage and surgical capacity being part of that. Unfortunately, the government's just lurched from crisis to crisis, and it seems to be fixated with humanitarian aid. Well, of course, that's only a sticky plaster. over what, getting to the root cause of the issue. We know development works, but development requires long-term thinking, long-term funding, and an investment in people and being able to upscale projects that you're doing, working with host governments in order to do that. I want to see more investment in public services across the Global South. That is what we should be supporting, is sustainable development. Unfortunately, we have had a government that's only looked at sort of the work that we're doing almost in a sense as charity and very temporary. And I think we've got to really make that shift and think about, well, what does long-term development, what does having access to universal health coverage, investment in public services, why isn't it that we are exporting the NHS to places like Kenya and other places, and investment from private, from government, from donors? It's got to be a combination, hasn't it? But it's a really, really good question, and it certainly, I've learnt a lot, by the way, and I'm going to go away and sort of really ask this question as to why, what proportion of that funding that we give, especially in certain countries. I've just come back from Afghanistan, and I tell you, it was really heartrending to go to a hospital where a lot of children are in there because of malnutrition, but they hardly have any equipment, and you do have doctors. I mean, that's the other challenge, and some of the equipment just doesn't work because, if you've got shortages of electricity, well, that is going to really impact your ability to serve your population. So, yeah, no, really good. Sorry, Nema, did you want to add anything?
The only thing I would add is also, I think surgeons for a long time have just been in theatre. I mean, for most of my career, I spend most of my time in theatre, and unless I make an effort and we create that space for surgeons to come out and advocate for their patients, I think that's why we've lost out, and that's why we've been neglected, is we have not been at the table defining issues with regards to global health, and we have not been part of decision making and part of developing solutions, and so we need to catch up, and we need to work very, very hard. Yes, it's critical to be in theatre, but we also need to fight for our patients so that they also get the resources that they need, and so that people recognize the importance of surgical care, and more importantly, people invest in surgical services.
Great. Dina?
I was thinking that it's not just the surgery. We make the same argument for some non-communicable diseases. For example, it's really hard to find funding for diabetes care, especially among certain groups. Again, there's certain, and I was wondering, I think what you said was really essential actually, is the political optics of, imagine you are trying child health days, immunization. In one day you could immunize 10,000 children, or you could do this big scaled up, maybe superficial thing, awareness raising of something, antenatal care, things that could be done cheaply and for lots of people, and you show results. With surgery, with other diseases where it's difficult to show immediate impact, say diabetes care, people with cardiovascular disease, and we know among children especially, it's really neglected. And in a sense, how do you show you have managed the disease well? It's difficult to document, difficult to show impact. So I think that's one of the key reasons, the need to constantly have this impact and demonstrable. That's driving a lot of the sort of efforts and assistance. So in terms of the HR issues, I think the task shifting, so there's been a lot of good, good examples of even people with 2 years training, where they conduct a specific set of procedures, so very limited. They're trained on, it's not just the length, they're trained on a very set of procedures with a lot of support, and there are countries, Peru, various other countries where they've done, for example, triage. They'll do operation, but they'll discuss with somebody at district level the procedures and all that. So they're wonderful examples. But I think the shortage of, I don't think it's training. So we are finding that from studies that are in Kenya, there are huge amounts of unemployed doctors, unemployed health professionals. Why? Because in many countries there is a lot of violence. For example, in Bangladesh, violence against doctors, basically, in facilities. If the outcome is not good, the family will come and attack. We know this is happening right now. Insecurity, the lack of career progression. For example, Ethiopia established this very big program of health extension workers 10 years ago, and that was something that Dr. Tedros was designed. the idea is that they started, these healthcare workers, they only had initially 9 years schooling, and then they were trained 1 or 2 years, and then they work, they perform a lot of, not surgery, but they do minor things. However, they were promised that they'll be in this role for several years, and then they'll progress, and they'll become maybe trained to be a nurse. So that was why they accepted very low pay, extreme, because it was the idea of you do progression, like a junior doctor here. You do your work and then you progress. However, they're still there, and there is a massive attrition because there is no understanding of their sort of situation. They have families as well. They have to. They can't. Some of them are really low payment. I mean, it's just $50 a month. They live for free in somebody's house, and so I think it's not just the numbers trained. Ethiopia has started something like over 60 private colleges to train different types of health workers, and they have huge amount, and they are actually overtraining until they emigrate abroad and so forth. So there are no positions, there are no actually places for them to work, and so attrition, retention is really the key thing, and the fact that people are not supported. They will be sent somewhere far. They don't have the opportunity for continued training, for career progression, for improving their situation, providing good care. They're saying we are just alone. There is no opportunity to learn and to improve care. So I think we need to look at more. But there are a lot of interesting models. It's very often it's also regulation. It's difficult, for example, in some places nurses, they could do minor surgery, nurse practitioner level in Latin America, but the law doesn't allow them to do it, so they almost do it anyway, informally. So yeah, there is also a governance issue in health systems.
Great, I think we've got one final round before we sum up of questions. Brilliant, we've got 3 questions here in the front row. We'll start with you.
We talk about health for all since the 70s. The World Health Organization has published frameworks, recommendations about health system strengthening since 2007, which is the same year the revised International Health Regulation entered into force. We witnessed 6 public health emergencies of international concern, yet according to the Institute for Health Metrics and Evaluation of the University of Washington, 5.4% of the funding from the 3 big donors of global health, that is the United States, the Gates Foundation, and the United Kingdom, goes to a system-wide approach health system strengthening. Are we talking about lack of political will, health system strengthening being too complex and lack short-term measurable outcomes, or we are talking about a behavior to create aid dependence?
Great question. Your question?
So we kind of talked about a lot of the building blocks for the health systems. I kind of wanted to question the health information system side of things. How important is health information systems using data that's produced from that for evaluation and kind of showing how important surgery is, how cross-cutting surgery is in creating impact in that wider health system?
Great. And your question?
Hugh Bailey, one of the commissioners of the Independent Commission for Aid Impact, but I also have another part-time job as a lay member of a nursing and midwifery council, and there's lots I can say about training and cost shifting. But I'm particularly struck by something, Nima, that you have said twice, that health systems don't serve the most vulnerable. And we know in this country that it's easier to get a doctor's practice in Surrey than in Sunderland or Strathclyde. And you have talked about the massive health inequality between Turkana and Nairobi, and wherever you go. I've seen that in Ghana, between the north of the country, and Accra in the south, and seen it in South Africa. So can we use health inequality as a tool to make sure that you don't leave the poorest behind, that rich countries and poor countries consider the inequalities between them, that we in even rich countries look at the need to service everybody? But there's no single magic bullet to improve the health system. You tend to go to a vertical fund if you say immunisation is the answer, or we get the biggest health gain from it. So there's got to be a whole series of interventions, and you've been mentioning them, and I don't disagree with any of them. But can we use focusing on the most vulnerable as a tool?
Brilliant. Those are great questions. I'm going to ask those questions just because I'm conscious of time differently. So, Nema, maybe on the last one, if you can, whether health can be used around inequality, whether you want to answer that question. And then I will come to Ben, you for health information systems, and then Dina will talk about why the biggest donors were only contributing 5.4% to health systems. Brilliant. Kick off with you, Nema.
So that's an excellent point, because what is measured gets done, right? And sometimes things are kept opaque intentionally, so that there's no accountability and there's no one to blame. But equity, I agree with you, would be a powerful indicator to use, and to use everywhere, because the systems are everywhere, and systems are used to organize populations. And the way they've been set up historically do not benefit the most vulnerable, and that's how things have been. And I think the first step is to recognize that. To recognize that we have disparities all over the world, and that if we want things to be different, then we need to radically change those systems and recognize that we are all interconnected. And the more inequity persists, there's no way we will all actually achieve prosperity as human beings. So if the person next to you is exposed to TB, you're more likely to get TB. and so we need to also recognize the fact that we are interconnected. We all depend on each other. And equity, and ensuring that there is equity, is the only way out, whether we're considering climate change, whether we're considering COVID-19. The reason the pandemic has persisted is that we did not vaccinate the whole world immediately. And so I agree with you that equity can be a measure, a powerful measure of our progress and of whether we are heading in the right direction.
I can't remember what the question was, but never mind, because I've only got one thought left in my head.
Is this your closing remark as well? Maybe you want to incorporate it.
It must be. I think we think of health as a cuddly, nice, nice. Everyone believes in health, don't they? Except they don't. So if you're a gay man in Kampala, your ability to access healthcare is significantly different than if you're a gay man, I don't know, living in London. If you're in Tigray at the moment and trying to access one of those clinics that we talked about that FET, for example, has helped develop, you're actually the other side of a systematic government policy to use lack of access to health as a weapon of war. So all I say is, and by the way, one of my favourite books is Norman Fowler's book, which is called AIDS, Don't Die of Prejudice. And it's an echo of a book of a campaign that he ran when I was at university, which was AIDS, Don't Die of Prejudice. Don't Die of Ignorance, I beg your pardon. And the book is called AIDS, Don't Die of Prejudice. And it's a famous campaign for those of us who were around in the 80s. And the book is very interesting because he explores, how he persuaded Margaret Thatcher to offer free needles to drug users in the streets of Edinburgh, which everyone, as in Russia today, thinks was actually a way of encouraging drug users to use drugs, because you were giving them the equipment, as opposed to thinking this is a public health measure, etc. Anyway, it's a really good book. And Norman Fowler, that Thatcher, government minister, ends up sitting down with, you know, transvestites in Australia, drug users in Russia, gay men in Uganda, and gives this fascinating series of insights into why health is not just a cuddly, we all believe it's a good thing. It's actually it's a contested area, and it's hard work achieving universal health coverage in those circumstances.
Great, thank you so much. Tina.
So again, I don't have a great answer, and sadly, looking at over time, for example, there were times where the Global Fund said that only 30% of their funding was supposed to be for health system strengthening, and they said it was not claimed by the countries. Clearly, there are a lot of obstacles for the countries to request these funds. That's part of the barrier to accessing these funds. So what they've said 2 weeks ago, the Global Fund, for example, to take as an example, that they are really believing in this diagonal approach because they feel the way they get funds is with these diseases, for these several diseases. And the only way to strengthen the system is to do it almost, my impression is undercover, because if they announce we're strengthening systems, I think they'll lose funding. That's the impression that I'm getting. That's what a lot of these donors are thinking, but they think that there is a way to integrate it in their programming. So again, it's difficult to commit upfront. It almost has to be done on the back of something else. So that's still why I think we don't have this debate sufficiently. But I have something positive to say. I think we looked at the other crisis and COVID as a shock to the system, and that has made a lot of donors to really starting to reconsider. So I've been to a few meetings where people are suddenly saying, we need primary healthcare, effective primary healthcare, we need integrated services. So I think that has been quite a shock, and our analysis is that these debates change because of shocks. If it's business as usual, nobody will change anything. I think that's, we can see what happens now. Finally, I would like to just mention about the equity bit on the positive side. The only, when we've looked at the policies of different countries, very often the equity is not on the political agenda. Basically, the governments are not saying that they care about equity. They care about expanding coverage, they care about access to services, quality services, but not equity. However, places where equity has been really put forward as a key driving principle of policy development, such as Brazil, for example. Why? How did it happen there? The social movement. So, you know what happened in the 80s with the HIV/AIDS. Even now, the fact that even the Bolsonaro didn't abolish Bolsa Familia, the primary healthcare program. Why? Because it's such a big social movement. There will be people on the street. Here, if NHS is abolished, there is more and more private care I'm observing coming in. I don't see people particularly, maybe they'll go on the street, I don't know. But this is big, the fact that health systems cannot change internally. They change because of political landscape, social movements, pressure. So that's the important thing. You can't just change health system from the health system. So, yeah, and finally, I think this is what, especially the white paper that we were referring to today, talks a lot about resilience. I think the debate and the response to COVID has really shifted the debate, not just health system strengthening, but what do we do about resilience? And so we see this new debate. I don't know whether we'll have the same conversation in 2-3 years' time. I hope not.
Oh, that's absolutely fantastic. I've learned so much, and I'm sure you have. It's been a really brilliant discussion. One thing I would say, and I can say this because I'm the politician on the panel, is that, look, the government has tried to stoke culture wars. What we've heard today is very, very important. It's about, how do we strengthen health systems everywhere so everybody benefits and we don't leave anyone behind. And of course, during the pandemic, nobody expected Britain to be navel-gazing and restructuring a world-leading department and then to callously cut the aid budget. And so it's really important that all of us, if we care about this issue, you asked the panel about some of the things that they will do, but when you go away from here, really do think about contacting your MPs, especially if you live in a Conservative area, because they need to know that people do care about this. I've seen the solidarity between the British public, and if the government thinks actually that British people don't care about the suffering of the rest of the world, it's got a lot to learn, actually, because, we saw it with the deck appeal for Ukraine. I mean, it was just phenomenal, actually, to see people step up. So I think it's really important, as you said, it's the public that can hold the government to account. Write to them and tell them that you care about this. Tell them that you care about the fact that they are cutting the budget, and that you care about surgical capacity, and that this is something that we do need to focus on when we're looking at health funding, not just situations like Gabby where it's just about focusing on immunisations or different aspects. So thank you so very, very much, and I'm going to call David to do a final thanks.
Thank you very much, everybody. I shall quickly try to summarise. Thank you so much to our chair, Preet Gill MP, to Professor Dina Balbanova, and to Dr. Nema Kaseji and Mr. Ben Sims. You've given us an excellent discussion and led us through that tonight. Preet started by reminding us that we are in the middle of a pandemic and no one is safe until we are all safe, and that people everywhere deserve access to quality healthcare, questioning, as others did, how this can be achieved if we are cutting the aid that we give. Nema explained that existing health systems do not serve the most vulnerable. Women and children are being left behind, and we live in a world where we all where we will feed a child and give them a vaccine, but will turn a blind eye to a broken leg or a burn, leaving them at best disabled for life. You'll have to excuse me, I'm trying to read my own writing. It's terrible. Ben highlighted that it was not only a lack of access, but also a lack of quality care that was killing patients, and that increasing quantity simply wasn't enough. Ben reminded us too that economic health could not be considered without public health, and highlighted our own reliance on doctors from overseas, with 1 in 3 doctors working in the UK having been born abroad. Dina highlighted that we don't yet have a clear definition of what a health system is, which makes the challenge even more complicated. Worse yet, the structural barriers that exist to stop a patient even reaching hospital are often overwhelming, meaning that even a strong health system will need to tackle these upstream challenges. And of course, this is ultimately a political problem. The technical solutions do exist. We then enjoyed a wonderful Q&A, and thank you for contributing so strongly to that. That again highlighted the need for investment in local people, investment in local infrastructure, and in surgery as an effective means of improving care for all, but especially women and children. And how could we forget Ben, and I use his own words, I definitely wrote it down correctly, where he said, "I'm coming out as a diagonalist," recognising, I think, success in disease-specific interventions was also wanting to strengthen the system. We discussed pandemic preparedness, questioned why surgery is overlooked, and explored how we can bring more people into careers in healthcare. And as Nema explained, as important as it is for surgeons to operate, they must also advocate if wider change is to be achieved. And finally, we asked if there was a political will for change, or were we happy creating a world that was dependent on aid. We asked about the importance of health data in decision making, and then we closed by asking how we leave no one behind, especially the very most vulnerable. This has been a fascinating and informative evening. We have explored the causes and the potential solutions to the question of why health systems haven't been strengthened, and I hope that this is a conversation that will feed into decision making here in the UK government, indeed in governments around the world. I'd like to thank our chair and our panel who have been first class, and to all of you for joining and for contributing. Thank you so very much.